Drug Information Training for Pharmacists, Module 17. Medication Misadventures. Introduction. All adverse drug events, ADEs, ADRs, and medication errors fall under the umbrella of medication misadventures. Adverse drug reaction refers to any unexpected, unintended, undesired, or excessive response to a medicine. A medication error is any preventable event that has the potential to lead to inappropriate medication use or patient harm. This module focuses on ADRs, highlighting the impact of ADRs, pertinent definitions and classifications, specialty drug information resources, ADR reporting systems, and future approaches to detecting and managing ADRs. Do stay connected. Thank you.
Good evening, distinguished men of honor. It is my pleasure to moderate this meeting today. I'm yours sincerely, Pharmacist Augustine, Ajijelek. And based on the program we have had, we are supposed to we are supposed to start with an opening prayer. And I know we are people of various faiths. We are a very blessed house. So we'll take 5 minutes for everyone to just pray according to his faith in some silence. And then we would commence the program proper with our agenda. Thank you. So may God guide this meeting and use it to improve our practice in our various professional and occupational corners. Amen. So with this, I would like to recognize to this group the group coordinators, under the leadership of Shade. I don't know if she's here. I would have loved to give her the time to recognize other group coordinators who are present. And I can't see her name among the participants now. And if she has not joined, is any other group coordinator present?
Kindly go on, please.
You can
kindly go on. Kindly go on.
Okay.
Yeah.
So we appreciate all group coordinators who are here. As a matter of fact, from our busy schedules, it's very difficult to coordinate a group. And we appreciate the effort you've been making so far. So even in absentia, we recognize all the group coordinators present. Also, we want to recognize all the fellows of the Pharmaceutical Society of Nigeria, fellows of the West African Postgraduate College of Pharmacists who are here, our professors who are our tutors that keep churning out pharmacists year in, year out to meet the healthcare departments, directors of Pharmaceutical Pharmacists Council of Nigeria, other distinguished, very important personalities and distinguished participants. You are all welcome to this program. So without much ado, we would like to set the ball rolling, and it would be important to mention the people who will be taking us. I speaking, I'm Pharmacist Augustine Ajijelek, as I told you before. I am the moderator. I work with Johns Hopkins Program for International Education in Gynecology and Obstetrics in Abuja. I'm their private sector consultant. We also have among Jonathan MC Pan, is a superintendent pharmacist, UIT Pharmacy of Fada, Ogun State. He would be the first presenter for today. And then the second one, whom I am very pleased to meet again virtually in this meeting. He's someone I used to meet as a young medical rep at Federal Medical Center, Nguru, as the head of department. It's great to meet him in this particular meeting and to know that we are going to benefit also from his speech. And that is pharmacist Ibrahim Doma, member Clinical Pharmacists Association of Nigeria, member Nigerian Institute of Management, and FCAI. I'm not sure of those. He's of the Department of Pharmacology, Bayero University, Kano, and the Pharmacy Department, Federal Medical Center, Nguru, Yobe State. So as you can see, of course, there are other members in our group who would also be bearing part of this responsibility with all of us. Permit me to recognize them, to mention their names, so that we would know that this is a group work that has been done collectively, and those who are speaking would be speaking for the group. Sorry. Apart from these ones I have mentioned, there is pharmacist Bello from University of Ibadan Teaching Hospital. He has been a very active member of the group and has been of a lot of motivation to the group. As a matter of fact, he more or less keeps the group together. We have pharmacist Oluwayomi Peter. We also have pharmacist Rukaya Ibrahim Kankara. Then we also have pharmacist Tamuno Miebi Douglas. I wouldn't mention the ones who are speaking and moderating today so that we don't repeat ourselves. And in the absence of any other matter right now, I think I'll go ahead straight to call on the first speaker to give his own presentation at this time. And of course, I can see that pharmacist Ibrahim Bello is already sharing the slides, and pharmacist Ikokwu Jonathan would be presenting on behalf of the group. Thank you. Over to you, our first speaker.
Good evening, fellow colleagues and all fellows present. Well, warmly once more welcome to this lecture. So I'll be taking the first part of the lecture, medication misadventure, adverse drug reactions. I remain pharmacist Jonathan Ikokwu. Now, why study about medication misadventure? This is because medication misadventure can occur at any stage of the medication use process, from the time the patient meets the prescriber deciding on what to prescribe, to when the patient uses the medication and any other effects that occurs. All medication misadventure can occur in any of that process. And it is also responsible for the death of thousands of patients yearly in all clinical settings. So no setting is taken out, all clinical settings. Hence, as a result, all healthcare providers need to have a sound understanding of the risk of error when they handle medications, to have the ability to understand the underlying causes of medication misadventure, and to take responsibility for preventing such occurrences and minimize adverse outcomes. As pharmacists who are key providers of medications, we play a pivotal role in ensuring the safe use of medication from the point where the medication are manufactured to the point where the patient takes this medication. Please, next slide. So we'll take some definitions. First, medication misadventure. Medication misadventure is an iatrogenic hazard or incident that is inherent. It's always there when a medication therapy is indicated. It can be created when there is an omission or as an error of commission. It can be dependent on the pathology of the disease or the process through which the disease passes through. And it can be due to human or systemic error, or both, immunological response, or an idiosyncratic reaction. It is always unexpected and undesirable to the patient and the health professional, and can cause mild discomfort or fatality. Medication misadventure is a big umbrella. It encompasses medication errors, adverse drug events, and adverse drug reactions. Please, next slide. Now, medication error. What is medication error? Medication error is any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or consumer. Such events may be related to professional practice, healthcare products, procedures, and systems, including prescribing, order communication, product labeling, packaging and nomenclature, compounding, dispensing, distribution, administration, education, monitoring, and use. Now, we should pick some key points from this. The key points from that definition, please, that's okay, are that medication errors are preventable. And it can occur in any of the medication use process, from when the prescriber is deciding what to do to when the patient finally gets his medication. Also, medication error can be related to how these medications are packaged, and they may cause harm or may not cause harm to the package. Now, I'm talking about medication packaging or labeling, that is nomenclature. I did a survey. Please, next slide. Next slide, please. Okay, I did a survey. The covered word there is medication nomenclature. So the responses that was gotten on medication errors. Now, because in most clinical settings, handwritten prescriptions are given, and sometimes even those that use computerized system. Remember, I'll say this error can occur from deciding. So a prescriber may want to write down a drug, and along the line, he may write the wrong drug. For example, if you see this survey, we see things like losartan and lexotan. They sound similar, and they can be written for each other when that is not what is needed. Things like pitrophin, which is phenobarbital syrup, and pitrocin, which is azithromycin, as well as other brand name or drugs.
Can you unmute yourself, Dr. Jonathan? You are muted. Okay, good.
Okay. Okay, things like these can cause medication errors. Please, next slide.
Hold on.
Please. Okay.
Just hold on a bit. Hold on, please. That's why you. Okay.
Okay, now definition of adverse drug reaction and adverse drug events. An adverse drug reaction is a reaction that is nauseous, unintended, or undesired, which occurs at doses normally used in humans for prophylaxis, diagnosis, therapy of disease, or medication of physiological functions. For example, when chlorpheniramine is given to a patient, an adverse drug reaction we could see is sedation. That is an extension of its normal pharmacological effects. An adverse drug event then is an injury from a medication or lack of intended medicine. So adverse drug events always involve harm to the patients and involve both allergic or the idiosyncratic reaction, as well as medication errors that result to harm to the patients. It's given that statistically 3 to 5% of medication errors result in harm to the patient. So using the chlorpheniramine example, where chlorpheniramine causes Stevens-Johnson syndrome or toxic epidermal necrosis, that is resulting in harm to the patient, it becomes an adverse drug event. Please, next slide.
Sorry, lagging. Apology for this.
So talking about the chlorpheniramine example, I saw a study that they indicated the 3 studies. Can you hear me?
Sorry, excuse me. Excuse me, Dr. Jonathan. I want to suggest, yes. I believe the network is having some challenges. Maybe without your video, we may have a smoother transition of some of these things. I don't know, but maybe it's something we can try. Thank you.
Okay, let me put off the video. Okay, about 3% of hospitalized patients experience adverse drug events, according to the Harvard Medical Study. And in the Institute of Medicine in 1999 estimated that 44,000 to 98,000 persons are killed by medication or die as a result of medication error every year. That is 1999. So most systems have been able to work on their system to ensure that this number have reduced. Here in Nigeria, I couldn't see any cumulative data on the medication error that occurs within the country. Apart from deaths, it also causes a huge economic burden on the healthcare system as well as to the patients. But there's something of note, which is the next point. Please, a click. Please, just a click.
Okay. Sorry, but that's
while the slides come up, let me read it from here. It says, while it was initially thought that medication misadventures were caused by individual healthcare practitioners, including pharmacists, physicians, and nurses, now it is clear that our healthcare systems and processes are often a causative or contributing factors in the majority of errors and events. So the keyword there is healthcare systems and processes. And no doubt many of us working within the Nigerian healthcare system know that truly most of these errors are as a result of how our system is positioned in situations where pharmacists don't go to the bedside of patients, as well as information may not be readily available to the community pharmacists to adjudge the why certain medication are given or why certain doses are given, as well as where follow-up is not usually done. Please, next slide. So how do we identify and report these adverse drug events? One is institutional reporting. That is the use of intervention registers or forms within each clinical setting. 2 is the national reporting system. In Nigeria, we have the NAFDAC pharmacovigilance program, where yellow forms are supplied to hospitals and those who request for it, as well as the online reporting. The link there takes us direct to the online reporting. Next is international reporting system like the MedWatch and the International Institute for Safe Medication Practices. Okay, next slide, please. So how do we classify these errors? The American Society of Health System Pharmacists have outlined some classification. We'll consider some of this classification and break it down into their smaller units. In our common parlance here, we use the word drug therapy problems. So let's consider these drug therapy problems. or medication errors. Please, next slide. The first is incorrect patients. This occurs when a drug is given to the wrong patient because of improper patient identification and confirmation. Sometimes because these patients have waited for their drugs, once you call a name, where the surname may not be the same, but when they hear a particular first name, patients rush out to take their drugs. That can result in incorrect patients. And tied to incorrect patient is incorrect medication, where the wrong medication is given to a patient. The next is incorrect dose. This involves when a dose is too high, is too low, a dose is omitted, an extra dose is administered. Where it's not a drug therapy problem, that can be recorded as incorrect dose. It can also occur when the dose administered to the patient is different from what was prescribed. According to Pepe, it's in 1995, he said that it's the second most common cause of error in the medication use process. Please, next slide. Next is incorrect route of administration. For example, where IV artemether is given to a patient, knowing that artemether should strictly be given as an IM. There is also a case of a patient being administered pastry clotrimazole, and at the end of the day, the patient went ahead to take it per orally. So that is an incorrect route of administration. The next is incorrect timing. Now, recording incorrect timing as a medication error depends on organization, institutions. Institutions may define certain criteria for this. For example, when a drug is given 8 hourly, an institution may say, okay, this becomes a missed dose within 30 minutes or within an hour. So it depends on the institution itself. Next is incorrect rates, number 6. Either the rate is too fast or too slow, or where the rate of the medication is unknown, perhaps a new medication. That can result in a medication error. Number 7 is incorrect duration. This occurs when a patient receives the medication for a shorter period or for a longer period than what was prescribed. For example, in the case of asthma, the use of the controller medication should be used for as long as possible, but certain patients may just use it once the drug finishes, they just skip it. So that can result in an error. Please, next slide. Next is incorrect dosage form. In this case, the prescriber makes an error in the dosage form that should be used, or during the dispensing process, an incorrect dosage form was dispensed. Then incorrect strength or concentration. This occurs where the incorrect strength is recorded in the prescription. This week, I saw a prescription carrying ceftriaxone 10 milligram. So that can qualify as an error on its own. Then incorrect preparation. This occurs where there is compounding errors. Either the medication used to compound the drugs is too high, too small, or vehicles or other things within the compounding process are incorrect. That can result in an error itself. Then we have the expired or deteriorated products. This occurs when an expired product is given to the patient, or a product that's deteriorated due to improper storage condition is given to the patient. Next slide, please. Then is medication that is a known allergen to the patient. So this can result to medication error or even medication harm. Then number 13, medication known to be contraindicated for the patient, such as where there is drug-drug interactions or drug-food interactions. Incorrect patient action. This occurs where the patient is taking extra drug to their medication. So this can be taken care of, especially at the counseling point, knowing what supplements or what herbal drug the patient is taking. Then, noting these drug therapy problems, how can we ensure that we have a system that can identify them as well as report them? We'll discuss that in the next slide. How to start and manage an event reporting system.
Go on, let me get it right. Go ahead.
Number one, develop and utilize standardized definitions and classification for errors. For example, the error on incorrect duration. We could develop a standardized method should an error be reported as missed dose when the medication is taken after 30 minutes or after 1 hour. This needs to be put into consideration, as well as other definitions that are important. Number two, assign responsibility for the error review program within the pharmacy and throughout other key departments. This involves an interdisciplinary approach where responsibility is given to members within the pharmacy department as well as within other healthcare departments, so that the errors can be identified during the medication use process. Number three is develop forms or online methods for data collection and reporting. So this involves developing a standardized intervention form, or even asking the patients to call, or we collecting the phone numbers of the patients so that we'll follow up and identify whether there was an error during the medication use process. Number four, promote awareness of the program and the importance of reporting errors and adverse events. Now, this involves letting key members within the healthcare professional know how to identify, if possible, and report these events where they see them, as well as letting the patient know that this can be possible when voluntary reporting from the patient side or following up. Also providing feedback back to these persons so that they will also know how to take steps to prevent them. Please, next slide. Number five is develop policies and procedures for determining which errors, events, and adverse drug reactions are reported to NAFDAC or FDA. Now, this involves national reporting. So when these errors are identified within your healthcare system, what type of error and what is the severity of error that requires you escalating it to the national body that collects these errors. Number six, establish mechanisms for regular screening and identification of potential medication errors and adverse drug events to supplement voluntary reporting. So where there is voluntary reporting, there should be mechanism to screen through these prescriptions that are coming, as well as other things taking place when the nurses are administering the drugs, to know how do we identify these errors and try to resolve them, which is tied to number 8. Develop strategies for decreasing the incidence of medication errors and adverse events, and utilizing this data to know how to intervene. And lastly, review national resources that identify errors in other organizations, such as the Institute for Safe Medication Practices, the FDA, and the United States Pharmacopoeia. Once in a while, this institute, as well as even NAFDAC itself, may bring out policies or documents that will let us know more about these errors. So reviewing this can help us to know how to manage this event reporting system properly. So I would like to call on the second speaker to continue from where I stopped.
Good evening, colleagues. Good evening, sir. You are welcome to the second part of the presentation. I hope you are hearing me. Hello?
Yes, we can hear you.
Okay.
Yes, I can hear you.
My own part begins with the safety event analysis.
Okay.
Actually, safety events are occurrences or episodes that challenges or likely cause challenge to the medication harmonious use or medical appliances for achieving better health status. So Therefore, all the errors that my colleagues mentioned in the first part of the presentation refers to some of the events that actually are taking place to challenge the harmonious use of medication or medical appliances, because it involves both the medications or the medical appliances that are involved in trying to better the health status of an individual. Therefore, when such event occurs, a thorough analysis of safety events is a key activity to support learning from errors in an effort to prevent their recurrence. Therefore, there is a need to actually study what has happened, where the error is committed, whether it is small or big. There is need for that to establish the prevalence of, or to prevent the reoccurrence of such kind of errors. It is important, therefore, to remember that the causes of errors may be minimal, or they may lead to serious events. Irrespective of being minimal or serious, you have to analyze you have to do safety event analysis in order to prevent the occurrence. For example, a nurse administering a dose of cefalozine to the wrong patient. Fortunately, the patient was not allergic and there was no adverse outcome. If the same error occurs with a different drug, the outcome can be fatal. This is the need for us to actually analyze in safety events to see in order to prevent the recurrence of what is happening. Next slide, please. Hello. The types of events, safety event analysis includes one, sentinel events analysis. As sentinel event analysis as defined by TJC, which stands for the Joint Commission, which is an accredited body that is focused on continuously improving healthcare for the public by evaluating the healthcare organizations. They define a sentinel event as an unexpected occurrence involving death or serious physical or psychological injury or the risk of therefore. The expectation that the organization will conduct a timely, thorough, and credible root cause analysis in such kind of events, because it has caused injury or there is the risk of physical or psychological injury. Therefore, that will actually prompt analysis. So this kind of analysis is referred to as sentinel event analysis. There is the second word, which is root cause analysis. Of course, even in sentinel event analysis, you have to go back to dig and to get the root cause of what is happening. But actually, in any event, whether it is big or small, the root cause analysis is recommended. The goal of the root cause analysis is to investigate the event in such a detail that the true causes of the event are identified. This requires that the team completes a thorough analysis that includes reviewing the human errors and processes that may contribute to the event, an action plan. An action plan should be developed with the intent of preventing the occurrence. Therefore, such action plan will actually include documentation of even near-miss events. Near-miss events are some of the errors that do not reach the patient. If you think that you have committed an error, but you have seen that it has not reached the patient, therefore you are not likely going to worry yourself or take care of it. There is instances that such errors may actually reach the patient. So these are near-miss events. You have to analyze them in order to prevent their reoccurrence. And there are errors that can reach the patient, but you discover that they have not caused any injury to the patient. You are not supposed to get rid of to just do away with those events without doing analysis in order to prevent their recurrence. So it is always important to do root cause analysis. Next slide, please. The next slide is actually the failure mode and effect analysis. While this one is just trying, is another form of the root cause analysis, but this one is looking at the future, it's prospective. Why the root cause is you are waiting for an event to occur, then you are going to trace back and to see whether it has caused, what is the error that has been committed, has it reached the patient, does it cause any harm? So this, in other words, is a prospective process that is required. This type of analysis involves a team that takes an issue, just as my colleague mentioned that in trying to look to set up a departmental or an organizational approach in preventing errors, that there is need to establish a team. So this type of analysis involves a team that takes an issue that has been identified as potentially risky process and examines the way in which the process or product may fail. Whether you are thinking that this kind of a product, for example, typically in X-ray machines, if you have in radiology, you have an X-ray machine that is faulty, you know that typically such kind of fault may actually predispose patient to you are likely going to prevent such kind of adverse effects from radiation. Then you have to analyze this event under the failure mode and effect analysis. Next slide, please. There's also when looking at the event or errors that are being committed or likely going to be committed, the concept of the human factor is always there. Because by nature, human beings are likely they are not 100%. To err is human. Human beings, including all healthcare professionals of all types, have propensity to commit errors in all aspects of their life. Therefore, the understanding the mode of human performance is very important. Whether this human being is likely going to commit this error, because does he have the skill? Has any rule been established? Did he follow the rule? Is he knowledgeable enough? You need to understand this, because it is likely going to give you an idea whether such type of people would commit the error that is being perceived. Therefore, such knowledge is very important in understanding errors and events and in developing appropriate strategies to reduce the risk of recurrence. Poorly designed healthcare system and processes are significant contributor to individual human error and subsequent patient harm. Just as my colleague Jonathan said, the situation in this part of the globe, there are poorly developed systems, poorly equipped health institutions, and poorly ill-equipped health institutions and poorly functioning machines. There is likely and highest tendency of having such kind of human factor errors because of lack of skills and then poor establishment of rule basis, and then the knowledge, of course, is highly compromised. Next slide, please. The safety event analysis are always done in order to look at the process and look at the events that have actually taken place in order to establish where are the root cause of the problem. And in so doing, there are likely people that will be affected. Therefore, in doing so, there is the need to establish the just culture. One needs the establishment of justice in order to be fair to whoever that is involved. Has there in any rule that was set? Did he follow actually those rules? Who established that rule? Is that rule supposed to be the ideal rule that is supposed to be followed? If that rule is established and he followed that rule and he commit error, then there is some people that are equally going to be part of those blame. Therefore, the justice culture, a just culture is one in which discipline is applied in a consistent manner based on the intentions of the individual and the situation in which they were placed, not on the outcome. It is not always the outcome that you are going to look. What is the situation that he finds himself? What is his level of intent? Did he commit? Did he? How? Where? What is his level of mind? This mindset in trying to in committing such kind of errors. For promoting just culture, all health professionals should be trained. Therefore, there is need for training to deliver patient-centered care as members of an interdisciplinary team, emphasizing evidence-based practice, quality improvement, and approaches in informatics. Next slide, please. Next slide. Despite the establishment of the just culture, of course, culpability also must be established, because the use of a series of questions to help to determine the culpability and accountability of person for determining the culpability of unsafe acts. Because just because we say that to err is human, it's not right to allow all human beings to be committing error just because that human beings are supposed, they are not 100%, they are likely going to commit errors. The mindset or the intended actions of that particular person or persons that were involved must be analyzed to establish culpability. Was the person that was involved under the influence of unauthorized substances? If, of course, is taking any intoxicant and he commits an error based on his interaction with such kind of substances, then, of course, he's liable to whatever error that he commits. Did he or she knowingly violate a safe operating procedure? If there is an established rule, there is a pattern that is established as a procedure, and he deliberately violated those kind of safe operating procedure, then of course they are likely going to be culpable. If so, was the procedure available, workable, and correct? Then in such kind of procedure, it has to be established. If a procedure was established maybe before by somebody that is not experienced, that is not knowledgeable, and then he found himself of somebody who is knowledgeable, and he followed another procedure, he cannot be held liable because those procedures were not correct and they were not workable. This gets at those procedures that staff feel make no sense and are not value added in their workflow. Perhaps they have a point and there is a component of system-induced error. If the error is induced by the system, then of course, if he know under the rule of knowledge that he's aware that this system is wrong, he's not going to be held liable for not following the procedure. Do they pass the substitution test described above? If they are, will others have made the same decision, and if so, are less likely to be culpable? If not, were there deficiencies in training or experience? All these kind of questions are supposed to be asked in order to establish the likelihood of culpability. Next slide. Consequences. Of course, despite the doctrine of to err is human, and then if any culpability established, then there must be discipline. Somebody and somehow must answer or must be liable to liable to any error that he commits if it is established that he is culpable. And this is some of the consequences that appropriate discipline, when warranted, should be taken when unsafe behaviors are identified, regardless of the outcome. Irrespective of whether the outcome is harmful or not, but he has taken an unsafe, he has been found to be doing unsafe practices, then the appropriate discipline must be met out to him or her. Next slide. There are a lot of factors that are regarded as risk factors in committing errors and in events. And the ultimate purpose for identifying, classifying, and analyzing and reporting medication error is to enable individuals and organizations to implement better systems and prevent medication errors. So the whole thing is to avoid committing those errors, avoid these mistakes, avoid establishing risk reduction strategies, such as re-educating people, asking staff to be more careful. All these are things that are supposed to be established in order to better systems so as to prevent medication errors. So let's look at some of the risk factors that may likely cause errors. Next. Okay, some of them include shift work. You know what is happening in shift work? There are certain people that are on morning, for example, some people are evening. Whenever you are doing shift, there's somebody who is coming in and somebody who is going out. And in between those shifts, there's need for handing over. And if this handing over is not taken care of appropriately, so there's a risk of having such kind of errors and likelihood of events. So inexperienced or adequately trained staff, of course, we all know the importance of training, especially in healthcare system, where we have things that are always coming in, new things are being developed. So there's need to have a robust training system in order to take care of staff. Medical services with special needs, pediatrics and oncology, especially pediatrics, there's errors in handling pediatrics. And there was an instance, somebody forgot a tourniquet on a pediatric. When he was trying to apply, a drip was given, and then in the ward, they forgot a tourniquet. And this is a pediatric. He cannot say my hand, or he cannot complain. This actually led to a serious and physical injury to that particular child. So there is, of course, risks in handling pediatrics. Higher number of medications per patient. Of course, we all know in polypharmacy, when you have higher number of medication per patient, there is likelihood of developing drug interactions, and then increased side effects, and even adverse drugs reaction, which are all refers to some of the issues under drug complications. Environmental factors such as high level of noise, poor lighting, and frequent interruptions. All this one in a medical setting or hospital environment, if you have this kind of challenges, there's tendency of committing a lot of errors. High workload for staff. When you are short staff, the duties that are supposed to be handled by 6-7 people, you will only go and have 2 to 3 people. Unfortunately, this is something that is going, especially in our pharmacies, when the pharmacy is always left out. When in terms of staffing, you can see a hospital. I know of a hospital, a tertiary hospital, that was working for almost 2 years without one single registered pharmacist, until we were lucky then to have a medical, a board chairman that happened to be a pharmacist, who came and actually kicked against that and queried so many people that were working there. And then he established a robust pharmacy department. Poor communication among healthcare providers. Of course, in any establishment, if there is poor communication, there is tendency to commit error, and there is tendency to actually refuse, avoid the established friction between people that are not communicating well. Dosage form, more errors with injectables. Yes, of course. If you have dosage form, preferably injectables are always reserved. If you have patients that are not going to be able to swallow or take oral medications, and except otherwise they are highly indicated injectables are reserved for such kind of purposes, because there are a lot of complications that may likely errors that may likely arise in the use of injectable. A lot of them, such as drug category, improper storage, calculations. This is typical. I've seen a calculation. Unfortunately, somebody was supposed to prepare an extemporaneous preparation. In fact, it is a sildenafil. Sildenafil is employed in pulmonary edema in children, and it was sent to the pharmacy, and unfortunately the pharmacist was not around, and the sub-staff handled it, and then he sent that 6 tablets of sildenafil, and this is just an infant. 6 tablets of sildenafil. When I saw the prescription, I went and rushed and went to the pharmacy department and discovered that the guy that was there was a technician. I asked him, how did you arrive at this calculation? 6 tablets of sildenafil, and this an infant from pediatric ward? Then he said, this is how he did it. I said, no, this is not your work. You must always wait for the pharmacist to be around to make this kind of calculation. And of course, the child didn't require more than 1 tablet. So that was how we saved that kind of error. And you can see how tracing and root cause tracing of events is very important. From there, we make sure that no technician is going to handle any prescription except the pharmacist is around. Poor handwriting, of course, it will send a wrong communication. Verbal orders, because they are not documented, you have it's a risk of having errors. Lack of effective policies and procedures, all these can form risks of establishing. These are form of the risk. Next slide, please. Next slide. Are we there?
Hold on, please. It's hanging. Let me just correct it. Hold on.
Okay.
Okay.
Okay. Yes. Healthcare professionals have indicated that other factors may also contribute to medication errors. Some of these factors are as follows: lack of effective communication. I've said it even the other ones. Failure to comply with policy. If there is an established policy and you fail to comply, then lack of knowledge. Of course, this is a vector of many errors that are committed, because if you are not aware of if there's lack of knowledge, of course, there is high tendency of committing error. Lack of patient counseling, of course, this is very, very important, especially in pharmacy. And if you fail to counsel the patient, there is something that is supposed to insert through rectally, and then he's just going to, because it looks like a tablet, he's going to swallow it. So the patient counseling is very, very important. Very, very important. Next. Yes. Error prevention strategies. There are many resources available that identify best practice error prevention strategies. We have one here, the National Quality Forum, which is NQF, is safe practice for better healthcare, identifies practices that have been been demonstrated to be effective in reducing the occurrence of adverse events in healthcare. The safe practices associated in this chapter are as follows: medication reconciliation and pharmacist leadership structure. Other safe practices which relate to medication use include improving patient safety by creating and sustaining a culture of safety, improving patient safety by facilitating information transfer and clear communication. This is one of the cardinal reasons why we have drug information specialists, because if you inform, then errors are surely going to be avoided. Improving patient safety through prevention of healthcare associated infections, then improving patient safety through condition and site-specific practices. They are all error prevention strategy. Many of the practices involve medication use, and pharmacy should be integrally involved in efforts to meet these goals. Some core principles of human factor design include the following: simplifying and standardizing. Then you need to simplify and standardize, of course, following establishing standard and simplifying how communication, passing information, and simplifying even the prescription. There is no need to have a complex prescription. You simplify it, and then you flow standard. If they are established standard, especially if you through the monographs that are established, and then the functions of the drug and therapeutic committee by developing institutional formularies, then you are going to simplify and establish standard in respect of particular elements so that you can follow, and then things are going to be easy. And reduce reliance on memory. This is very important. Whenever you have established protocol, and don't feel and say that we have been doing this always, and just based on your memory, you just feel the errors in substituting drugs that are supposed to go to A may go to B, especially as my colleague Jonathan mentioned, some of the errors. It is substituting prescription, giving wrong prescription to a patient. Then if you base on memory that just this guy is coming for this, just you pick and give, then you are likely going to commit such errors. Use constraint and forcing function, mistake proving. There are systems that are involved now in trying to avoid mistake. Especially there are certain pediatric preparations now comes with caps that will not easily be removed until you press and apply force and then turn it. These are all strategy in proving, in establishing mistake proving devices. Improve information access, of course. The establishment of drug information units in every facility is going to improve that, and decrease reliance on vigilance. You cannot say that you just rely on, you are going to be extra vigilant. No, put functions. It's just like if you are going to apply, if you are going to start an automatic car, you must ensure that you put your foot on the brake, because don't say that you can just kick it and you are vigilant that nothing is behind you or in front of you. No, match the brake, then kick the car. Increase feedback. Then feedback mechanism is always important. In order, this safety analysis event is to look inward and to see things. And you can, there are those that are even prospective. You foresee, you futuristic, you foresee what may likely be wrong. Then you report back, and then from there, checks and balance are going to be established to prevent reoccurrence of errors. Reduce and or improve the reliability of an-op. These are all part of practices involved in pharmacy that are going to check the commission of those errors. On a final note, in my conclusion, we look at way forward. Of course, the way forward in avoiding commission of error and safety event analysis is researching. researching, recognizing, designing with human factor principle in mind is a great way to improve the safety of any process. If you keep researching, seeking knowledge, practicing, establishing standard and following them, then of course you are going to improve the safety of any processes. Healthcare will continue to be complex and require effective coordination and communication. I will conclude by saying that technology will continue to evolve. As we are seeing today, even robots are being programmed now to participate actively in human aspect of life. But safety truly needs to be a core value that is held by all. Teamwork, as we are doing today, and mutual respect are vital parts to success. Thank you, and thank you for listening to me.
Thank you very much, Thomas Ibrahim Doma, for these very scholarly presentations. I am personally very edified with these presentations, with the background that everything we are talking about has to do with pharmaceutical care. And in pharmaceutical care, we say we want to achieve definite outcomes that will either improve the quality of life or even elongate the life of a patient. And we can see that these medication misadventures can actually contribute negatively to the achievement of those outcomes in a variety of ways. Of course, good justice to that. A very good presentation and a very good refresher for me personally, and I'm sure for many also in the audience here. So we would now welcome contributions, questions, and other suggestions. And I wish to say that we need to take very seriously this issue of documentation. Most of the time, if you check in Nigeria, we don't have our own local data in our own context, our own local context that would be very helpful to us. It's there, it's disjointed. I think we need to find ways to bring all those together. And in our own little corners, I believe, as the first presenter did, and even the recommendations here, we need to begin to evolve ways of documenting these things, not necessarily the national ones, because we know dealing with the national data is a bit cumbersome. But I believe at the facility level, having data like this and reviewing it from time to time on a multidisciplinary basis will even improve the clinical skills of all those who are concerned with the business of healthcare in those facilities. And of course, with time, authorities could leverage on that, and it will help in planning, formulary making, and the rest of them. So please, I believe with these presentations, we should be putting some of these things in place in the places where we practice. So the floor is open for questions, comments. Thank you. Thank you. Please, we are not going to use just one means. You may raise your hand. I would recognize you to make your contribution or question, or you can even drop your question on the chat box and it will be read out to the presenter and other members of the group who should be able to do justice to it. So there's only one comment there. Yeah, well done to the lecturers and the organizers. This is appreciated. Okay. Yes, I can see pharmacist Folashade's hand raised. I assume that is pharmacist Folashade Lawa. So it's over to you, Ma.
Good evening, everyone. It's been work, and the much I was able to listen to of the lecture was very educative and informative, and I really enjoyed it. I just want to chip in a case I had the privilege to see one day. I went visiting somebody in one of the tertiary hospitals, and this patient was being administered methylprednisolone depot as IV through a drip set. So it just formed crystals around the the drip container, and it was the patient that was now raising, calling attention of the nurse. The nurse went there to try to shake it. I was just wondering what it could be. You know, sometimes they don't allow outsiders to intrude like that. But I was curious. And then I found out that that child was prescribed IV methylprednisolone, but they bought methylprednisolone depot. Now I was able to get to see the pack, the empty pack in the dustbin. And that empty pack, they wrote not for IV use. It was a product that was registered by NAFDAC because I saw NAFDAC number on it. Unfortunately, I could not write down or snap because they were already very agitated that I was intruding. So my own observation is that not for intravenous use should have been written in a different color from the background of the pack. Should have been so conspicuous that it will be the first thing that one will see. And that wasn't the case. So I'm thinking some of these errors, like pharmacists, Ajit said, we should document and then work on whatever we see to improve the system and avert further errors. So I think that some products that have special warnings, those special warnings should be very conspicuous, probably in red, so that it's easy for the whoever is administering to see it. Then it will also be nice if we can come up with documentation formats that can be moderately uniform to capture these errors and interventions. Then we can now start working on them and pulling data and pulling interventions, and then we can do a lot more on prevention of medication errors. Thank you. I don't know if I was heard.
Yes, you were heard for most part. There were a few instances you were dragging a little, but I think we got everything you said. So thank you very much, Ma, for your contribution. I can see pharmacist Ejiru Akwevu. Your hand is up. Please, over to you, Ejiru.
Thank you very much. I just wanted to find out from Madam the experience she just narrated, if there was a pharmacist in that facility and where the depot was gotten from, if it was from the facility or from outside.
Okay. Pharmacist Folashade Lawal, did you hear the question?
Hello? Hello?
Yes, we
You
can hear
called
you,
me.
Ma. Yes, pharmacist Ejiru just asked the question. That particular facility, was there a pharmacist there? And if there was, or where did they actually procure that depot preparation from?
It was a lot of intrigues that day. The prescription, apparently the patient's relation went out to buy. And where they bought, there was a pharmacist there in the premises, because I tried to be nosy about it. There was a pharmacist there who, after reading the prescription, selected that particular one for them based on cost. And the prescription was very clear. The doctor wrote methylprednisolone IV, so milligrams. So the pharmacists that attended in the facility, they bought it from a community pharmacy. The pharmacist gave them depot. Interestingly, according to the patients, I mean, the relation that bought, one of the doctors managing was also there when he bought it. And I think that person actually referred them there. There was a lot of intrigues around it. But you see, I was already being rebuffed, kind of, because they saw me as nosy. So there was some restrictions. I couldn't do much. I was just trying to trace where the error could have come from, since the prescription was clear, because I spied into the folder and I saw the prescription that the doctor actually wrote methylprednisolone IV. And you know the drip set has a tank. So the tank was just whitish, full of powdery something. That was when this patient raised an alarm. That was happening here. And then the nurse tried to shake it. And I was wondering, what was she shaking? Because any IV should not form crystals anywhere. IV should be clear liquid. So that's also drew my attention. Then I started asking questions, because it was a pediatric. So somebody was, there was a relation watching, taking care of the child. So I asked questions, and then I found out that that was what happened, because that person was able to get the empty pack. Because the doctor on duty was also invited, and that one was just trying to look for how to make it dissolve. And I was wondering what was happening here. So pharmacy, it still boils down to the gaps. Even if the drugs were gotten outside, for an inpatient on admission, it would have been nice if that drugs went through the pharmacist and the instructions are made clear.
Thank you very much, Ma. I think very practically, thank you very much, Ma. It's a situation I think most of us can relate with. There's a lot of secrecy in certain places, especially when an enlightened person in terms of drug therapy is trying to ask questions. And I think it's not very good. Sometimes we toy with the patient's right to know, because the caregiver of that patient, the person, the relative or guardian of that patient, was supposed to have been explained to, even if there was an error. But of course, our health system is evolving. And I think for those of us who work in the hospitals, even when some drugs are out of stock, I think it will be beneficial to the patients to insist that when they procure medicines from outside, when they bring them, the pharmacist should be able to see them and then give proper interpretation or instructions to the nurses on what they should do. Because sometimes I've even seen doctors who cannot really tell the different dosage forms, how they are supposed to be used. And that's why, of course, the pharmacist is like the last line of defense before these medications are administered. So we need to find ways. I know that in the hospital setting, sometimes there are lots of interests, and it's not as strict as we would want it to be. But I believe we can also find a way to interface with those who get medications from outside, that at the end of the day, the pharmacy will still be able to do the needful before those drugs are administered to avoid cases like this one. Thank you very much. Pharmacist Ejiro, I hope that does justice to your question.
Yes, but I still, now it's a comment. I want to especially thank pharmacist Balashadi. A lot of us much younger than you quite admire your level of I really wish that this discussion was taking place in a larger platform. It further goes to the need for pharmacists be on top of their game. This medication was bought from a pharmacy dispensed by a pharmacist who should know. It is not the duty of the medical doctor, the prescriber, to know what you dispense, how the particular brand you dispense, how it should be. It is the duty of you, the pharmacist, to let them know what you are dispensing and how it should be used. Now, a prescription for an IV cannot be written and then a pharmacist dispenses it. Therefore, those are completely two different things. So now this pharmacist is outside the hospital setting. It's a community pharmacist. He dispensed the wrong thing. Now in the hospital, the system was also faulty because they didn't have a system in place where the hospital pharmacist needs to verify and confirm what has been brought from outside before administering on the patient. And they also didn't have a system where the pharmacists in the hospital are around. If not for Olashade that have come into the picture in a setting where she was not practicing, you can imagine what would have happened, because the nurses and the physician would just be there trying to make sure that this thing actually goes into the patient when it was not formulated for an IV administration. So this clearly shows the gaps in our practice. It is very important, just as much as we want to more like be the police in the care process. It is very important that we be sure on our own end what we are doing. So I want to thank Pharmacist Olashade for this is just one of the many interventions he's known for. If we can have up to 50% of our pharmacists doing what Pharmacist Olashade does, a whole lot of the adverse events, adverse reactions will be drastically reduced. So there is need for pharmacists to up their game at all times. Thank you.
Thank you very much, Pharmacist Ejiro. We are very grateful for your very wonderful contribution. There are two hands up. The first hand to go up was Dr. Mrs. Obono. I think we will take hers first before Pharmacist Ibrahim Doma. Dr. Mrs. Obono, it's your turn now.
Thank you very much, and good evening, everybody. This has been very informative. Good evening. This has actually been very informative, and I was interested because in the hospital, these are a lot of what we come across. Like Pharmacist Olashade Lawal said, if there could be uniformity, we'll come up with a way of documenting. I know the yellow forms are there, but I don't know if we're really getting anything from them, and if we have data for Nigeria that we can quote. But different institutions find a way of documenting their adverse events. But all in all, I want to say that I wrote on the chat that if pharmacists were on top of their games, we have already identified a lot of gaps that need to be plugged or filled in patient care in the hospitals. Yes, this issue of nurses fencing you off, doctors trying to hide inefficiencies here and there, they are all there. But if we realize that it is the patient that suffers if we do nothing, then we will all at our different areas of practice try to come in at one point or the other. We have actually identified a lot of gaps, and that's why most times you're in the ward, the nurses are frowning, you pick up things, you write a note to the doctor, he's on the defensive and all that. But please, it's something we still need to continue to do, and above all, document, such that I wish this team, I really appreciate you. I wish this team could go into a study of gathering data from different institutions so that something is published officially as, you know, a way of tackling these things, and retrospectively what has occurred in the past, so that learning from there, we can move forward. Thank you very much. Thank you.
Thank you very much, Ma. Very apt points there, and they are succinctly put. Thank you very much. Pharmacist Ibrahim Doma, your hand has also been up. Pharmacist Doma.
Hello, thank you for letting me in. Can you hear me?
Yes, go ahead.
Thank you for letting me in. I'm very sorry for that unfortunate break in the transmission due to the network.
No problem.
Yes, part of what was highlighted recently is the issue of error prevention strategies. The error prevention strategies can be seen toward the last part of the slide, where there is need for medication reconciliation, and most importantly, pharmacist leadership structure. In this pharmacist leadership structure, it is recommended, or it is a must for all institutions actually to allow pharmacists to be champion of any drug-related matter. As part of error prevention strategies, there are other safe practices which are related to medication use. These include improving patient safety by sustaining a culture of safety, improving safety by facilitating information transfer and clear communication. There should be and must always be clear communication between caregivers in order to ensure error prevention in each of our settings. Hello?
Yeah, thank you very much, from Doma.
Oh, thank you.
Thank you very much. That's very important. And I think following these responses, I think one thing which is very important in prevention of these medication misadventures, and to either preempt, detect, prevent, and even properly manage drug therapy problems where they occur, we need to give a lot of visibility to bring out standard operating procedures, and then develop them into job aids, and make sure that we are using them across all the facilities. I think CPAN would really need to have, I think we can maybe, can I call it transmute or transform into a study group where we can look at some of these things, and then bring them, maybe have a scientific session where people can sit down and brainstorm and bring out whatever needs to be in these standard operating procedures, and then we can find a way to get them produced and listed in every single pharmacy in all the hospitals, so that some of these things would be checked. This particular example that Pharmacist Folashade brought, is subject to if the standard operating procedures are there and they are applied with fidelity. I believe some of these things would be checked at an institutional level. So it's a great thing that this forum is here and we are meeting regularly. I think we would be looking at some of these things as the next steps. And of course, even if it is to look at the technology that can have an integrated platform for the reporting of these ones, I believe even the national system can benefit from what CPAN can do. And this is just food for thought for all of us to be thinking about it as we continue to engage. We should be able to follow through with these next steps and do something that would be of help to the entire country. So permit me just to recognize the presence of Professor Adebola Shodiko, Professor Ismail Suleiman, and of course, Dr. Mrs. Obono, who has already spoken. So it's great to have these very distinguished personalities in our midst this evening as we discussed. Of course, Pharmacist Folashade wants to say a little bit more. Can we take that? Then I think we should be getting to closure because it's been a very long day for everybody.
Yeah, sorry, I know it's a long day, but sorry, it's just my passion here. Because I had one experience some years ago. This woman was looking for a child for so long, and she had one child in her old age. Now she took the child, had fever, and she took the child to the hospital. Unfortunately, because she did not have money to pay for drugs, they would not write a prescription for her. So one of the doctors decided to help her and told her to go and give that child Afan 5 ml 6 hourly, and then Septrin 5 ml twice a day for 5 days. At the time I saw the child, that child had taken 4 bottles of Afan because she thought that the child was to continue on the Afan for 5 days. So she was giving Afan 5 meals 6 hourly. And what pained me was that she was buying this bottle of Afan from a pharmacy. And she was buying a bottle, like almost every day she was buying a bottle and they were selling to her. So some of these lapses bring about a lot of errors. Luckily, by God's grace, that child is still there. We didn't lose that child, but we could have lost that child. Imagine a child on Afan 5 ml 6 hourly for 5 days, just because there was no pharmacist to handle the matter. She said the pharmacy she refused to give me the name of the pharmacy because I was ready to talk to that, my colleague, to say this is not what we should be doing. But she said the pharmacy was not, was working somewhere else and would only come at a certain time. So it was the sales person that was attending to her. And she was buying a bottle of Afan syrup almost every day. So we need a lot to do there. We need to work on ourselves. We need to work firstly on ourselves, honestly. We have a lot of work to do. Like you said, CPAN, standard operating procedures. I pray we're able to sit down and generate them and see that by not being there to attend to the patient, only God knows how many patients we have inadvertently harmed or killed. Thank you.
Thank you very much, Ma. This is so good. I believe I'm optimistic that we would be able to do something about the standard operating procedures. There's a message from Pharmacist Hamza. Kabir Hamza saying, I think having an electronic platform in the reporting system in our facilities that will operate electronic health record. We're in the process of developing that in my facility, that is FMC Katsina. And this will help in the process of reporting medication misadventures. That's very good. a nice one to see. I believe whatever progress you make from that, others would learn from you. But I believe when we are going to have this forum to discuss this, we'll be able to look at the work that has been done so far and look to harmonize existing efforts to have a streamlined one that would be easy to use and then that can be adopted for use nationwide. Thank you very much, sir. There's still one hand up. I think we will take this one as the last, right? So, Pharmacist Ejiro, one more time. Thank you.
Yes. This happened to be the core of pharmacy practice, actually, pharmaceutical care. I can relate with Pharmacist Folashade's passion. Now, while we are talking about drawing up a standard operating procedure for hospitals and the rest, Dr. Mrs. Obono can also relate with what we try to do with the hospital accreditation tool in Nasarawa, I think last year or 2 years ago. A lot was done, yes. The point still remains what Pharmacist Folashade have mentioned twice, and we've also mentioned before. Dr. Bono mentioned the same thing. Pharmacist Folashade didn't need an operating procedure to see that there was a problem in the infusion where a depot preparation was given for IV. He also didn't need a standard operating procedure to know that her fan should not be given 6 hourly forever. These are basic pharmacy backbone. So if every pharmacist play their role as pharmacists, whether in the community, in the hospital, if you are in the hospital, yes, standard operating procedures, verify whatever comes out from outside. The person who dispenses should not be the person who is handing over the medication to the patient. Yes, you double check. But if you play your role as pharmacist, do your round. Every hospital should have a drug information pharmacovigilance center, for crying out loud. Every pharmacist should do their round. It is only when you do the round you'll be able to see if patients are experiencing these adverse events. It is when you have a pharmacovigilance center that you can talk about reporting, documenting, collating data for analysis. So let's just play our roles as pharmacists. It is not rocket science. That basic knowledge we have as pharmacists, show it that you're a pharmacist, not just a tablet counter. By the time we start doing this over time, yes, the electronic system will come. Yes, we'll develop forms. They just play your role as pharmacist. If prescription comes, look at it as a pharmacist. If you dispense the medication, go into the ward as a pharmacist. If we do this, we can then build on this to talk about the electronic system and the rest of it. Whether in the community, whether in the hospital, wherever we are, let's just play our roles as pharmacists. That's my take.
Okay, Pharmacist Augustine, are you still there? Over to you. Pharmacist Augustine, I think he has a network issue. Okay, we lost him. So at this point, we want to call on Pharmacist Folasade Lawal to give the closing remarks. I think we lost the moderator due to network. Pharmacist Lawal, on to you to give the closing remark.
It's been a very interesting evening, and we have done a fair enough justice to this. I know if we had the old days, we wouldn't exhaust all there is to say on medication errors. That's our passion, that's our calling. And I'm particularly excited as, despite the stress of the day, we all created this time to be here. I recognize all the professors in-house, the fellows in-house, and I thank you all. And I know that with these steps that we are taking, the practice will get better. I look forward to excellent pharmacy practice in a short while. Thank you and God bless you.
Thank you, Ma. And at this point, we have come to the end of today's public lecture. I want to promise us that the recording will be made available. Yesterday, we had a practice. Now we combine yesterday's zone and today's zone to produce a very good video of this module by God's grace. So expect a complete video from yesterday's zone, doing the mock presentation, and today's zone. So we promise you a complete better video of this module. Thank you for coming. And next time is going to be another interesting one. Thank you all. And good night, everybody.
Thank you and good night, Mr. Ibrahim.
Thank you, Ma.
Thank you.
All our speakers, yeah, well done.
Thanks a
See
lot.
you. Yeah. Yeah.
Thank you. Good night, sir.
Good night, Doma. Thank you. Yeah.
Thank you.